Hello, I'm Jan Lathan.
And I'm Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Scott Tagawa. Dr. Tagawa is the medical director of the Genitourinary Oncology Research Program, the associate director of clinical research of the Division of Hematology and Medical Oncology, and also the leader of the Genitourinary Disease Management Team and co-leader of the Experimental Therapeutics Program at the Meyer Cancer Center at New York Presbyterian Weill Cornell Medical Center.
In today's presentation, Dr. Tagawa discusses the evolution of prostate cancer treatment by targeting the prostate-specific membrane antigen.
Did you know that Dr. Tagawa led the first ever in-human work that led to the development of PSMA-targeted alpha emitter AC J591, a PSMA-targeted copper agent, and also the PSMA antibody-drug conjugate, along with leading to phase 1 and 2 studies that resulted in the accelerated approval of sacituzumab govitecan for refractory advanced urothelial carcinoma, followed by the confirmatory phase 3 study.
He truly is an accomplished pioneer in the field of GU Oncology.
So let's tune in and learn from this global leader.
These are some research and financial disclosures that I'll leave it for a minute. The major disclosures of broad audience is that for the most part, I'm taking some slides that I've used for other presentations or adapted, and those were predominantly for a medical audience. So I'll do my best to make this broad. I do have so that a lot of the introductory slides are more broad. So in particular, the first 5-10 minutes will be on a background, and then I'm going to talk about PSMA, which I'll define. So what is advanced prostate cancer? So what is prostate cancer to begin with? So I'm going to imagine that most people have heard of prostate cancer. So beyond that, prostate cancer is the most common non-skin cancer to affect American men. It typically is the second most common cause of cancer death in men in the United States. Most men walk in the door. These are what are called clinical states. So most men walk in the door, and as far as we know, 100% of the cancer is within the prostate. Some of the times, no treatment is needed. They live their next 50, 60 years. They die of something else, never bothered them. And some of the times, either with or without treatment, cancer grows. That being said, even in these, to the right, we consider more aggressive disease states, even when we encompass all these disease states, because men can live for a number of years, men can die of other reasons. However, if a man is going to die of prostate cancer, we generally are talking about what's called advanced disease, and that's what I'm talking about here. For terminology, advanced, I'm talking about usually we're synonymous with metastasis, and we're going to get to different types of imaging and kind of what that means. Generally, that means that there's at least one cell that is spread beyond the prostate, often before diagnosis, but sometimes after diagnosis. There are terms that are literally being changed this year, having to do with, use the term castrate or castration. But for now, this has to do with how we started hormone therapy or not, and associated with that, what is the level of the male hormone called testosterone. So non-castrate is generally a term that some people call hormone sensitive or castration sensitive. No treatment, normal level of testosterone in the blood, and that disease state going forward is in that state, at least for some period of time. And then once that cancer learns to grow despite having a low level of testosterone in the blood, that's what we term castration resistant. So I'm going to show some what we call clinical trials. This is what we call a Kaplan-Meier curve. All this means is that everyone starts off alive. Everyone, including myself, will eventually die. So this is percentage that are alive, and this is time. It's going to be measured in days, months, years, etc. It's just one example of the blue therapy led to an average or a median of 3 months longer to live, which is we use that as a statistical tool, a time point. What we want to know really is the difference between the blue and the yellow. We call that a hazard ratio. On average, people on the blue treatment live about a quarter longer. So if someone's supposed to live a year, they get another 3 months. Someone's supposed to live 3 years, they get another little less than a year. That's kind of on average. And how that pans out to kind of, I think, in a more explicit example of why we do this, so we don't have to wait for everyone. But why this becomes important, this is, first one was a prostate example, was a kidney example, but someone that got this blue type of a treatment, may over here have a median of 3 months or so different, but basically having a chance of being alive 5 years or not. That's what we call the tail of the curve. So that's why, some of us will make a big deal sometimes about what seems to be small differences at a point in time. Okay, I'm finishing up kind of some terminology. This is just a bigger breakdown of some of those what we call disease states. When I first started training, so red means what I consider to have level 1 evidence. It's part of standard care now. We had surgery, we had radiation, we had some salvage therapy, and some hormonal therapy. That's it. There was no more red when I started training. And now we have a number of different agents, which is very nice. I'm going to quickly run through those in categories. So we have different types of hormonal therapy. A lot of this we call this AR, or the androgen receptor, which is the receptor for testosterone in the body. So a number of different agents, and there's this term they call androgen deprivation, which lowers the level of testosterone. But we have a number of different agents, and all of these are now approved in different disease states. We have chemotherapies. These are actually fairly sophisticated targeted therapy. We know some of the mechanisms of action. We know how this binds at a very specific point on beta tubulin. But generally speaking, it's still chemotherapy. What a lot of you out there will think of as chemotherapy, something that poisons cells. Luckily, it poisons the cancer much more than the normal body, but all of these have some side effects. Immunotherapy generally exploits the human being's own immune system, but sometimes not utilizing these, but I'll get to some that might generate some kind of a separate type of immune type of response, but using the immune system to kill cancer. Bone targeted therapy, so prostate cancer happens to affect bone a lot. And we have some agents that make people live longer or better by targeting bone. Molecular selective therapy, some people call this targeted therapy, but these are all in fact targeted. What I mean by this is there's some sort of a test, and those that have, that positive test might benefit from these therapies. Those that have the negative test, we don't know, but probably are less likely to benefit from these. And then other, which may be combinations of these, but as I mentioned, these kind of other category to patients in the clinic, I generally am referring to clinical trials. So, for we call solid tumors, so tumors of organs, breast cancer, lung cancer, et cetera, the main kind of pillars of treatment are surgeons, radiation oncologists, and medical oncologists. My bias, as you see up here, is that when we work together as a team, then that's much better for the patients. And then I've expanded that to pathologists and radiologists. And I think even, when we have, other parts of the healthcare system, other parts of family and community. I'm throwing a dog. It could be any sort of pet therapy. I'm a dog lover. But my bias is that when we can get all these components to work together, that's in the best interest of the patient and their family. So don't worry about the specifics here. I showed you all that different red that was here now that should not be there, all the different categories. One thing that we now know, a man walks in the door with advanced prostate cancer, and we give more than one drug, many different combinations are possible, that man is going to live longer. In my mind, it's not a little longer, it's a lot longer. So this is just on average, that little line that we talked about 3 months before. Well, with this, just 2 drugs versus 1, we're looking at closer to 3 years at that median. Another way to look at this, what's the chance of being alive at 8 years or 10 years? Well, it's a lot higher just by starting the same drug at the very beginning than getting that same drug or a similar drug down the line. So it just works much better. So major advances The same drugs that led to months difference now lead to years difference. And this is something that, this is a little bit old, but this is something that is very disappointing to me, and I want to get the word out. So you're a doctor, you're a patient, you know someone, I'm sure all of you know people at risk, meaning people that have prostates. We need to get the word out, because even in the most recent era, this is a population of ASCO doctors, so medical oncologists, but still the majority were not getting at least 2 of these drugs. So that's 2019. I think it's improved in 2020, 2021, but still is a major problem that we need to make sure is minimized. So be your own advocate, or be advocates for your friends or family. I said prostate cancer. Generally speaking, we're talking about adenocarcinoma of the prostate. There are other what we call primary tumors of the prostate. These are just rare. And then also, when I say prostate cancer, usually I'm meaning adenocarcinoma. There can be these that start, or this can change into different types. I'm not going to have time to go into this in great detail, and not all of us agree with this terminology, but all of us do agree that there can be changes over time, changes to what we call the phenotype, just in terms of where it is in the body, how does it act. That can change over time. So all this knowing is half the battle. At least have to recognize that, and then figure out what we can do about it. We know not just it looks and behaves different. We know that the RNA may be different. We know that the DNA may be different, and we know that this happens not uncommon. And then this is one of my final kind of introductory slides before I get into PSMA. We now know that prostate cancer is very heritable. So there are a much larger population of patients with prostate cancer out there that have familial or inherited genes that lead to many different types of cancers. I don't have time to go into great detail as part of this talk, but that is important because it might lead to certain types of treatment. I mentioned on that molecularly selected treatment, we have certain genes that are either inherited or in the tumor, probably a much bigger benefit from certain types of treatment. There's also what we call the cascade effect, is that this might run in the family, and there are screening as well as preventative measures for many of these different cancers that are out there. These are not restricted to men. The ones that have in common are often breast and prostate cancer, but they span all sorts of different cancers. Okay, so take-home message from the kind of background. Hormones are important as a general rule, but sometimes they're less important, so we need to watch out for that. Taking more than one drug, it looks like in some situations, 3 is actually better than 2, but beyond that, we just need to get most men getting more than 1. I didn't mention this, but so bones are very important, but we don't want to kind of have overkill to some of these drugs at the very beginning, unlike other tumor types where bone met's the bone met. We want to treat that early. And now we have multiple drugs, all sorts of different types of mechanisms. And prostate cancer has what we call entered the precision medicine era, meaning we can find certain things and pick the best type of a treatment. But we need to remember that no patient can benefit if there's not testing. And some of these testings has, as I mentioned, cascade implications for kids, brothers, sisters, grandkids, etc. So how do we translate this? I'm going to spend most of my time talking about a very specific target. At the end, I'm going to mention how I think that the principles that we learned from targeting this protein called PSMA can translate into improvements in other cancers or other targets. So to take a step back, a very common question is, where's my cancer? How much cancer do I have? And, it doesn't matter what cancer it is. We generally look at imaging, scans to figure out where that is. And there's x-rays, ultrasounds, but most cancers have used either what we call cross-sectional imaging, CAT scan or MRI. Prostate cancer commonly goes to bone, so we've traditionally used bone scan. But there's which is a type of a scan in nuclear medicine, but there's many other approved nuclear medicine techniques, mostly different types of PET scans. And there's many more types of PET scans that are listed here. I'm only listing here really the ones that are at least of relevance to prostate cancer. with the most common ones that we're going to talk about today listed here. The problems that we've had with historical imaging is they're not sensitive enough. They're also not specific, as I'll show you, or not entirely specific. And because of those problems, may or may not change treatment options. That being said, we've had them for a very long time. So we have a lot of data on them. We have decades of follow-up. So when something is abnormal in one of these scans and it is cancer, it means a lot.